welcome. My name is Paul Houle. I'm a neurosurgeon at Cape Cod Hospital and Falmouth Hospital, and we've just opened an office here in Plymouth, and I thought it'd be a wonderful opportunity to introduce myself and talk about topics that are interesting, or I find interesting, which is golf and back pain, and what's out there and what we can do about it. And it's not working. All right. So a little bit about me. I'm originally from Warwick, Rhode Island, and I trained at Boston University School of Medicine. And during my third year at Boston University School of Medicine, I was able to rotate at Cape Cod Hospital. So that's how I became familiar with Cape Cod Hospital. And part of medical education is to become a neurosurgeon. I did my postgraduate education at the Medical College of Georgia, which happens to be located in Augusta, Georgia. And for those of you who are golfers, you might have heard they have a little tournament down there. And I was fortunate enough to be able to participate in that tournament as a four caddy on the first tee, where I got to meet a couple of golfers. And you may recognize my BFF, and that's Mark O'Meara. And if you're interested, there's a funny story how I actually got this picture. If anyone's interested and you just grab me later, I'll tell it to you. But because I get interested I've played golf my entire life, and I treat a lot of patients who also like to play golf. There's always the question of when can I play golf? How do I get back to playing golf? And believe it or not, there's not a whole lot out there in the literature to tell people or to advise doctors when to get people back to playing golf or how to get people back to playing golf. So I was doing my research and I came across a group called the Titleist Performance Institute. And TPI, or Titleist Performance Institute, is affiliated with Titleist. And Titleist, they make golf balls. And they found that the longer you play golf, the more golf balls you'll lose, and the more golf balls they'll sell. So it was in their best interest to make sure that people played golf as long as possible, so they get interested in the fitness game. And Titleist Performance Institute really likes to study how people swing and what physical limitations people have and how they can overcome them so that they can enjoy the game of golf. So that's why I get interested, and I'm actually a Titleist Performance certified instructor and the only neurosurgeon in the world who happens to be. We might as well just get this out of the way because everybody wants to know about Tiger and what happened with him, and I'm not privy to anything that happened with him. But people, after Tiger won the Masters after his spinal fusion, people come to me and say, I want that. Well, it wasn't that made him better. That set the stage for his recovery. It was the rehab and the exercise that he was able to do afterwards that got him back. And just remember that Tiger Woods is an elite athlete, and we're not. And he has access to the best trainers in the world. He has the means and the time, because that's his job, to exercise and to get back into peak physical condition. And if we all could do that, we'd have much better outcomes whenever we have surgery. So, does the golf swing cause back pain? Or is it something else that is responsible for pain when we play golf? I would tell you that when you study the kinematics or the motion of the golf swing and how your ankle and your knee and your hip and your back and your thoracic spine and your shoulders interact with each other when you produce a golf swing, there are certain physical characteristics and limitations that occur when we have injuries or degeneration that cause us to swing poorly, that puts abnormal stresses on our back, and that's why we get back pain. So for instance, as we get older and get problems with our hips, the limited rotation in our hips can cause us to focus stress on our low backs, and that can lead to back pain. Likewise, the limited mobility of our thoracic spine can also focus forces and stress on our low back to cause back pain. So our upper spine, our thoracic spine, the way the joints of the spine are oriented allows for greater rotation and flexion than the lumbar spine. In fact, they studied professional golfers who had low back pain, and they did their range of motion exercises and found that the professional golfers who experienced back pain actually had fairly limited thoracic mobility. They were then able to direct a physical therapy program and exercise to address that so that they wouldn't have back pain. The good golfers, of which I'm not, have very good, they turn their shoulders and their hips, whereas bad golfers turn their backs, and that's why we get back pain when we play. So what you'll hopefully by the end of this learn is that a lot of the things that you do in physical therapy for back pain, even not related to golf, have to do with increasing flexibility of your hip and strengthening muscles that act synergistically to get them back in balance to treat back pain. So what happens to your golf swing, say, when a nerve is when a nerve is irritated? So let's just say you herniated a disc and pinch a nerve, or because of a narrowing of your spinal canal or spinal stenosis, the nerves start to get irritated. What happens to your swing? Well, the main driver of your golf swing that gives you power are your glute muscles, your butt muscles. And it just so happens that your butt muscles, your glutes, are innervated by the L4, L5, and S1 nerve roots. Those nerve roots correspond to the levels of your lumbar spine, L4, L5, and S1. The most common levels to be affected by pathology are the L4-5 and the L5-S1 levels. And so it's no surprise to us that the conditions that we commonly experience throughout the course of normal life that give you sciatica will affect your golf swing, because the L4 and L5 and S1 nerve roots go to different muscles that make up your gluteus maximus, the big butt muscle, the medius, which is a little bit smaller, and the minimus, and they all have to do with your golf swing and generating power. So even if you have just a little bit of sciatica, a little bit of pain going down the leg, those muscles then don't function properly. And the golf swing is a series of well-timed sequence of events that, if it's altered, will cause you to try to compensate to bring that club head square to hit the ball. So if the kinematic sequence of the golf swing is altered a little bit, you'll start to recruit other muscles to get you back on plane, and that can lead to injury, further injury, and further back pain, or more back pain. And even when your pain resolves, goes away, your swing can still be affected because it takes a while for the muscles to get strong again. And during that short period of time where your pain's gone but your muscles haven't caught up, you're prone to injury. So somebody like a famous golfer who has one surgery, who then goes back maybe a little too soon, can develop another injury at the same time, or leading to another surgery. So that's an important concept to keep in mind, that even if you stop feeling pain, there's still some dysfunction, and that's why you need to rehab properly. So we talked about the kinematic sequence, and what this graph shows is how your hips, your thorax, your arms, and your club, how they're accelerating through the golf swing. And lots of things can affect how that happens. So there's a concept of reciprocal inhibition. And what that means is that in order for one muscle to contract, the corresponding muscle has to relax. So in order for you to move your bicep muscle has to contract while your tricep muscle has to relax. For the golf swing, if you spend a lot of time sitting in a chair, that's what you did for your whole life, when you sit down, your hip flexors will start to get short and tight, and in a state of contraction. The reciprocal muscle, which is your glute muscle, has to relax in order for that to happen. Therefore, you train your butt muscle to become weak, and that can affect your golf swing. When the muscles are weak and you have to recruit other muscles to rotate your hip in order to swing the golf club, that's called synergistic dominance. So it'll get other muscles, you recruit other muscles to assist you with the golf swing. We'll talk about that in a second. And the last concept that can cause limitations in mobility is we call arthrokinetic inhibition. So if you have a problem with a joint, the muscle that goes across the joint can get inflamed and it can become weak, and that will cause you to recruit other muscles to assist with your golf swing, which then leads to injury. So there are conditions that alter the normal patterns of your golf swing. We call them the 4 T's, trauma. People think of accidents, that's pretty dramatic, but what about your posture if you sit all day long? Think about what we all do in the course of a day. You wake up in the morning, you go and you sit down, you have your cup of coffee. You get up, you get into your car, you sit, you drive to work. You get to work, you get out of the car, you sit down at your desk. Then you get up, you sit down for lunch. You get up and you sit down for the rest of your day, and then you drive home. You see you're spending a lot of time sitting, and that leads to muscle imbalances. Thoughts will affect your golf swing, and even though a brain surgeon, I'm sorry, I can't help you there. Toxins, what you eat or drink, can affect your overall health, and life is too short to drink cheap wine and bad scotch. Words to live by. And then technique will also affect your golf swing and your normal patterns. If you learned a poor technique, it can lead to injury because it leads to recruitment of muscles that were never meant to be utilized during the golf swing. So I've been hinting at is that our lifestyle actually predisposes us to have back pain because of these muscle imbalances. And so I don't know if any of you in the room have had back problems and gone to physical therapy. What do they have you do? They have you work on your hip flexors, and you're probably sitting there like, I came in with back pain. Why are you stretching my hips? Because you get muscle imbalances. Well, my back hurts. Why are you making me do sit-ups? Well, it's because a lifetime of sitting causes the core muscles to become weak, and that's something that they need to work on. So there's something called the lower cross syndrome where the reciprocal inhibition that we talked about causes muscles of posture to become affected, and those affect your golf swing. And these lead to characteristic swing faults and postures that predispose you to experience back pain when you play golf. So one of the most characteristic postures that leads to back pain is called S posture, and it's due to this lower cross syndrome where you have weak glute muscles. And so perhaps maybe some of you have taken lessons where they tell you to stick your butt out. That's actually wrong. That creates an S posture. And it causes you to have to recruit your hamstring muscles and your back muscles to rotate your hip in order to swing your golf club. That causes undue stress on your lumbar spine and causes you to have back pain. There's something else called the reverse spine angle, and that occurs whenever you extend your back away from the ball. And that has to do with, again, bad posture and weak muscles and weak synergistic muscles. And what happens is that as you're in your backswing, because of limited mobility of your thoracic spine and hips, it causes you to come up as you enter in your backswing, and then as you go into your downswing, it causes unnatural compressive loads. And so when you hit the ball, you're compressing your spine, which leads to disc herniations. And that's one of the characteristic swing faults that people have as a result of a bad hip or stiff spine. So we talk about the characteristic swing faults, but what happens as we age? So talk about some of the common spinal conditions: herniated discs, spinal stenosis, and facet arthropathy, which is kind of related to both of them. So herniated lumbar disc can produce symptoms called sciatica. Sciatica is actually, there is a nerve called the sciatic nerve, and that's composed of multiple nerves that distribute nerve endings to your muscles in your legs and also give you sensation on your skin. L4, L5, S1 happens to be one of the more common contributors to that sciatic nerve, and so whenever you herniate a disc or something at L4-5 or L5-S1, you'll feel it shooting down your leg. Spinal stenosis is a generalized narrowing of your canal that occurs as a result of repeated injury to the disc and collapse of the disc and enlargement of the joints and enlargement of the ligaments. It generally narrows your spinal canal. The symptoms of spinal stenosis are pain when you stand for any long period of time or walk any distance. It gets better when you sit down or bend forward at the waist, such as when you go to the supermarket and lean over the shopping cart. So the next time you're at Stop and Shop, take a look, and you'll see everyone walking around in the shopping cart. Give them my card. Just kidding. Facet arthropathy is the arthritis that you get in your spine when people say you have arthritis. And typically it's the pain you get in the morning when you wake up, or when you try to stand up straight, you get the pain in the back. That's due to the arthritic joints that are stressed because of lack of support. So what happens is, if you think about over the course of a lifetime of bending and lifting and twisting and getting out of the car and lifting your groceries and picking up your kids, the disc, which is what people say is the shock absorber of your spine, really isn't. It's really meant to break up a long bone, because your spine is basically the same length as your leg bone, your femur, but your femur doesn't move. But your spine is meant to move. So in order to make your spine move, it has to be cut up into little pieces, little segments, and that disc is what allows it to move. Well, over the course of a lifetime, that disc starts to wear out because the blood supply to that disc is very, very poor. And so the ability for it to heal itself is significantly impaired. So over the course of time, that disc is injured, and it starts to lose its water content, so it starts to shrink. So as it starts to shrink, it puts stress on the joints. And when you put stress on anything, what does it do? It gets bigger. So when you're lifting weights, you're stressing your muscles get big. That's why I've got such big arms. And in response to stress, as it gets thicker, the diameter of your spinal canal starts to go down. So there's this degenerative cascade over the course of a lifetime that leads to dysfunction and pain. And that's where I get involved. So I'm a surgeon, and that's what I do for a living, but I actually operate on very few people that I see. Studies have shown that most people with spinal conditions will get better given proper treatment. However, if these conservative treatments fail, then surgery actually can be very effective in treating your pain in very specific instances. But it's very important to understand that surgery just sets the stage for recovery. And I'm very careful to set the expectations for people with surgeries that don't expect to be 100% better the day after surgery or the week after surgery. Because in most instances, it takes years, months, sometimes years, sometimes decades to get to the level of dysfunction for you to require surgery. It's going to take sometimes months to rebuild all those things that you've lost over the course of months to years. So surgery sets the stage for recovery. And I don't just say this because it's in my best interest to say that surgery is going to help you. There's actually a very powerful study that was conducted that randomized people to surgical treatment and non-surgical treatment. And what they found was that most people will get better if you do nothing. Conservative treatment, physical therapy, chiropractic treatment, epidural steroid injections, non-steroidal anti-inflammatory medications, your Alevs and Motrins. Most people will get better. But those people who don't get better, most of those people will improve if you have surgery. So the sport conclusions were that after a reasonable amount of time of treatment, most people get better, but if people don't get better, surgery is an option for them. So now that surgery is an option, how can we make surgery better? We hear about minimally invasive techniques. So if you think about how gallbladders used to be treated, it used to be an incision like this long. They would take out the gallbladder. It'd be just tremendously painful. But then the laparoscopic techniques came into play. And so even when I was a medical student, patients used to come in for their gallbladders, would stay for 3 or 4 days in the hospital, and now it's an outpatient procedure. A long time ago when they used to do knee surgery for torn cartilage, it used to be a big incision, and now it's just done through a little incision in the knee. You can even tell that you get it, and it's an outpatient procedure. Well, the same evolution has occurred with spine surgery. I was trained to do big open surgeries. So someone would come in to have a disc surgery. They'd have an incision 2 or 3 inches long. They'd spend 3 or 4 days in the hospital and then go home. But what do we actually do when we do surgery? So for spinal stenosis, the traditional surgery is called a laminectomy. And it's called a laminectomy because the roof of the spine is called the lamina. And so the removal of the roof of the spine to enlarge the canal is called a laminectomy. To remove a disc is called a discectomy. And both procedures, when performed open, require that you strip the muscles off of the spine, remove the roof of the spine and some of the joint. That gives you access to the spine, and you can treat whatever you're, either remove the disc, or if it's stenosis, then you're done. But we just talked about that most people get better with conservative treatment like physical therapy and strengthening those muscles. So does it make much sense to go in there and completely destroy the muscles that you just spent months trying to build? Because when I strip the muscles off of the spine, I rob them of their blood supply, so I devascularize them, and I rob them of their nerve supply. I denervate them. So what happens? The muscles die. So those muscles that you just spent 12 weeks or 8 weeks trying to make strong, I destroy in the matter of a minute. And then I shave down the joints to make the spinal canal wider, but now I've robbed the joints of the support of the ligaments and the muscles to support them. So guess what? You get back pain because those joints are under stress. So that's why there's been an evolution to try to make things more minimally invasive. So let's talk about spinal stenosis and laminectomies. So I don't do open laminectomies. I do minimally invasive laminectomies through a tube. So rather than a 3-inch incision and stripping the muscles off of the spine, the incision is about the size of a quarter, and I go through the belly of the muscle, so I don't destroy it. Rather than removing the entire roof of the spine, I just make a small window in the roof of the spine and remove the thickened ligament and just part of the thickened joint that's causing the narrowing of the spinal canal and the pinching of the nerves. This preserves most of the structures that provide stability and support of the joints. I perform it as an outpatient surgery, so you come in, you have your surgery, go home the same day. I do insist that people do physical therapy afterwards because, again, surgery sets the stage, but you don't achieve the full benefit of the surgery until after you've had physical therapy. So this is just, this is my view through the microscope. And this is looking down. This is a drill. It's a very expensive Dremel tool. This is a suction, and I'm drilling away some of the bone. I use a little tool to strip away the ligament. I use another tool to remove a little bit more bone, and this yellow ligament, or the ligamentum flavum, is what's primarily responsible for the stenosis, and I simply resect it. And these are some veins, and as you'll see here, the nerves are this bluish area, and I take away that thickened ligament, and when I'm done on one side, you'll see that the nerves themselves are completely free of compression here. This is the nerve that goes down to the leg. This contains the other nerves going to other lower structures. And then because it's usually a bilateral thing, I just reach underneath and take away from the other side. So I'm able to do a full laminectomy through an incision that's not much bigger than the size of a quarter. I put a single stitch to close covering the muscles, some glue, because I don't like to use staples, so that you can take a shower that same day. And it's a really minimally invasive way that is that is not as destructive as a regular laminectomy, that allows you to have a greater mobility and more function, and much less pain and a quicker recovery. And I've been doing it this way for almost 18 years now. Now, disc herniations are slightly different. And I used most of the time to do these minimally invasively, but in the last 4 or 5 years, I've really changed the way I do this surgery. I call it the Joymax procedure because the official name of the procedure is called the Transforaminal Endoscopic Surgery System, or TESIS, which that's just too much to say and no one will remember, but people will remember Joimax. And Joymax is the name of the German company that helped develop the instruments to perform the surgery. And fortunately, our spines have a natural opening called the neuroforamen. It's basically the hole where the nerves exit the spine. And if your instruments are small enough, you can actually go right through that hole and access the pathology, the herniated disc. And so by accessing the spinal canal through this hole, you avoid all the muscles altogether, you avoid the joint altogether, so you don't make anything weak and you don't introduce instability, so you don't have a lot of postoperative pain. This procedure in my hands is patients come in, they actually get themselves on the operating room table themselves. I have you lie on your side. It's done under local anesthetic with sedation, kind of like a colonoscopy. I'm able to perform the surgery and interact with you. I do it awake because part of this procedure involves me inserting tubes using x-rays. And if I'm going to irritate a nerve or injure a nerve, you'll tell me before I would injure your nerve because you say this hurts, and I simply change my trajectory. I've done over 400 of these, and I've been fortunate enough to be able to go overseas. I traveled, initially when I learned, I went to Germany, where the company's located, and watched a couple of surgeons there. I did a fellowship in Korea because in Asia, this is the only way surgery is done. It's in its infancy in the United States. I'm the only one in Massachusetts right now that does it this way, although I've trained a bunch of surgeons in Massachusetts, and it will become more and more popular as time goes on. And so I have a little video that shows you how it's done. This also shows my video editing skills, and shameless promotion of all pictures of me. But what you're going to see here is, obviously we always want to identify the herniated disc. This is what an MRI looks like, and right there is where the patient had a problem. When I'm operating, I insert a needle down into the spinal canal and then a series of dilators that open up a hole so I can access your spine. And so this is just a cartoon that shows I'm able to resect a little bit of bone to enlarge the hole where the nerve exits the spine to access the herniated disc. This would be the nerve exiting, and I'm work away from that. I'm able to then insert a tube in an endoscope so I can see everything, which is what you see up here, and remove the herniated disc. Any bleeding or any other loose tissue I can coagulate with it's called the bipolar electrical device. And this is actual picture during surgery. This is actually the herniated disc right here. Sometimes it takes more than one bite to get it, but there's a big disc right there and pulling it out, and that just shows all the tissue. I still have a little bit of work to do, but that's inside the spinal canal right up there. So the incision is about the size of a number 2 pencil. A lot of patients don't even take pain medicine after surgery, although some people do. But this has been my preferred method now for the last 4 years or so of removing herniated discs because people get back to normal activities much faster than they would if they had an open procedure. So, if I haven't said it enough, surgery is just the beginning. Surgery sets the stage, but rehab and exercise gets you back into the game. And so I really started to get more involved with the Titleist, and because there is such a lack of literature out there or direction for us to direct people on how to rehab so they can go back to playing golf, I teamed up with one of our physical therapists who also happened to be Titleist Performance Institute certified, and we wrote an article and a method of rehab to get you back to playing golf. And it incorporates 3 phases. The first phase is protective tissue healing and getting you to have a neutral spine. The second phase is to get your core really nice and strong. And then the third phase is to get you back to your muscles strong enough to endure the kinematic sequence. All the phases and the exercises themselves are demonstrated on the Titleist website. And if you send an email to golf@neurocapecod.com, it's an autoresponder. It'll automatically send you a link to these articles. So if you ever want to look at the exercises and maybe incorporate them into your warm-up routine, you can certainly do that. And then at each stage, we increase the complexity and the intensity of the exercises so that by the time you get to phase 3, the exercises that you're doing are pretty intense, and it gets you strong so you can go back to playing golf pain-free. So we're actually pretty advanced at Cape Cod Hospital. I would never have expected to be this advanced, but we have some equipment that helps us that you don't even see in some of the academic institutions in Boston. One of the procedures that we do, because our population on the Cape is a little bit older, we do a procedure called balloon kyphoplasty where we treat fractures. We're one of the busiest centers in the Northeast, and we do more of these procedures than all the Boston hospitals combined. We also utilize cutting-edge technology to do more complex surgeries like spinal fusions, and we do a lot of spinal fusions. None of us like to do them, but sometimes that's the best option, and we utilize a technology called the O-arm from a company called Medtronic, and what they do, what this allows us to do is take a CAT scan of you while you're in the operating room and send the data of your spine to a computer that then tracks our instruments, and it allows us to place our screws very accurately. Since we started using this 6 years ago, we haven't had a single bad or malpositioned screw or had to take someone back to the operating room because of bad positioning of the screws. So it's something that's allowed us to do surgery much more safely, much more accurately, and actually much quicker. You know, we also do a lot of brain surgery, believe it or not. One of our doctors, Dr. Copa, was actually a fellowship director. A fellowship is extra training after you finished your residency, and he does something called skull-base surgery, which is removing complicated tumors from the base of your skull. So all these things are available at Cape Cod Hospital. Just a little bit about my partners. On the left is Dr. Pabba Vasilio. This is me. This is Dr. Lepla, who will also start seeing patients here in Plymouth, I think, in 2 weeks. This is Dr. Nakata, and this is Dr. Copa. Dr. Pabba Vasilio and I did our general surgery internships at Dartmouth, and we used to be stuck in the White River Junction VA hospital covering for the weekend, absolutely nothing to do. His parents had a place in Falmouth, and we used to talk about how when we finish our residency and become neurosurgeons, we're going to go into practice at Cape Cod, and we did. And we've been together now for, we've been partners, not that kind of partner, but partners for the last 17 years. Dr. Nakata was trained at Brown University, and he was in private practice in Northern California. And while he was at Brown University, he married an ICU nurse, happens to be my cousin. And we were looking for someone to replace our partner who was getting ready to retire. And I knew that my cousin missed her mom, so I called my mom, and she called her mom, and he ended up taking a job for longer hours and less money. I feel bad about that, but anyway. And then this is Dr. Copa. Dr. Copa was the fellowship trained and the fellowship director at the University of Oregon. So he was a professor at the University of Oregon. He actually grew up in Cranston, Rhode Island. So the next town over from me. Oh, did you? He went to LaSalle and then Providence College. And I love him because he has the thickest Rhode Island accent. So it just reminds me of home. And then Dr. Lepla joined us 2 years ago. He actually was in practice in Springfield, Massachusetts, and then went to Reno, Nevada, where he was the head of the neurosurgery department out there for the last 17 years. His daughters came to school out here, and he wanted to retire, to come back out here and eventually retire out here. And he's been with us now for 2 years. So I'd just like to say thank you very much for coming. We are now seeing patients here, and we'd be very happy to take care of you. I sincerely thank all of you for coming, and thank you. Have a great evening.